going on, guys? Jazz here and welcome to another video. So I thought what I would do today and what I'd make this video about would be my approach to chest x-rays. Now I would say chest x-rays are like at the base of the big mountain that is radiology, and it's kind of something that everyone should know how to interpret at least relatively well. Like, it doesn't have to be perfect, but I think everyone should kind of know what's going on with a chest x-ray and have a relatively good idea of what they're looking at. Because you never know, say you're the medical student, you're on a general medical term, and you know how physicians like ward rounds, so you're on a big ward round, everyone's there, the registrars, probably fellows, consultants, interns, residents, etc, etc. So everyone's walking around, and you know how everyone's got one of those computers on wheels, and so you never know when you're going to get tested. So you're walking down the corridor, you've just seen a patient, and then all of a sudden the consultant turns around and goes, "Who wants to look at this chest x-ray for this patient?" And everyone turns around and doesn't make eye contact, because if they can see you, then they can pick you, so everyone turns away. But if you watch this video and kind of learn my tips to making chest x-rays easy to interpret, then you could just look them straight back in the eye and be like, yeah, pick me. Alright guys, let's get into it. Now, I know in university they always go on about this ABCD technique for assessing chest radiographs, and I have to say, in all my years of being a radiologist or a radiology registrar, I have not used that method once, and to be honest, I don't even really remember what it is. So my method is a lot more simple, and I'm sure most radiologists will use this kind of pattern to assess a chest radiograph. So firstly, you want to start off with the projection itself. So this is a frontal projection, but it's important to know whether or not it's an AP study or a PA study, because that can have, I guess, implications for assessing the cardiac silhouette, which is the second thing that I always look at. And the main thing you're looking for with the heart is whether or not it's enlarged and if there's suggestion of cardiomegaly. Now, cardiomegaly, reference-wise on a chest radiograph, usually the heart silhouette should be less than 50% of the thoracic diameter. Now, in regards to projection, it's important to know whether it's AP or PA, because an AP study will always exaggerate the cardiac size. And if you're not careful, you'll end up overcalling cardiomegaly when in fact that it's actually within normal limits. So you've assessed whether or not the heart is greater or less than 50% of the thoracic diameter. And so in this study, be happy that it's a normal, under 50%. Then the second thing you want to move on to is the mediastinum. So the mediastinal structures are kind of the midline thoracic structures adjacent to the heart. And I guess the main things you're looking for here in regards to the radiograph is that you want a nice, clean and narrow superior mediastinum. So this area that kind of like sticks up above the heart, you want that to be nice and narrow, no focal bulges or gross widening or anything like that, because that can have implications for certain pathologies. So the structures that you can see, so you've got the aortic arch up here, and then descending aorta, and then the ascending aorta sitting behind here. So you've got the trachea that just kind of sits up here in the superior mediastinum. And then you've got vascular shadows as well, such as the SVC, which runs along up down here and through this region here. And the other thing that kind of lives up in here a lot of the time is just you can get lymph nodes. So if you get focal bulging, you'd be worried that there could be a mediastinal mass, or it could be lymphadenopathy. And then also the other thing to be, particularly if the superior mediastinum is grossly widened, and say you've got an elderly vascular path presenting with chest pain, then your primary consideration there needs to be of an aortic dissection, and which is obviously life-threatening, so it's very important to pick it even if it's on a chest radiograph. Okay, so we've assessed the heart, and then number two, we've assessed the mediastinal shadows, so we're happy with all of those. Then you kind of move into the next step, which is the next thing over, which are the lungs. So the first thing I look at with the lungs is, are the lung volumes symmetric? And in this study, this is normal, so these lung volumes are symmetric. The main things to be considering, so you can either have reduced volume in one lung, both lungs, or you can have increased volume in one lung or both lungs. So thinking about reduced volume, say if you've got unilateral reduced volume, then the primary considerations you're going to be thinking about is there collapse? Is there an obstructing lesion causing collapse? So they would be the main things that you'd be thinking there. You can also get infection and consolidative change that can reduce the lung volume as well. Then if you've got bilateral reduced volumes, then the main thing you really got to think about there is it's probably just the patient's taken a reduced or a poor breath in, and that's why the lungs are not as expanded as they should be. And then we move on to increased volume. So if you've got bilateral kind of symmetric hyperinflation, then you'd be thinking about things like chronic airways disease. And if you've got unilateral kind of hyperinflation, then you'd be thinking about things like kind of focal air trapping or congenital kind of hyperinflation and things along those spectrums. So look, and then you get various types of opacities within the lungs as well, whether they're alveolar opacities, which you see in infection, your interstitial opacities, which could suggest, pulmonary edema. And you can also get kind of scattered ground glass change, which could either reflect hemorrhage or pneumonitis. These things obviously are always a lot more clearer on a CT, but you can usually get a pretty good idea off of the X-ray as well. So now we're happy with the lungs. We've assessed the parenchyma. We've looked for, infection, fluid, mass, anything like that. And we're happy that these lungs are clear. Then we'll move even more peripheral to the pleural spaces. So the pleural spaces being the outer lining of the lungs, we're looking primarily for fluid. So on a PA projection, which is taken with the patient standing up, the fluid will obviously move to the gravity-dependent portions of the lungs, which are usually these costophrenic angles. So the first sign that you usually see is generally kind of subtle blunting of these costophrenic angles, which will suggest the presence of a fluid. Sometimes you can get either fluid or densities within non-dependent portions of the pleural spaces, and that could either suggest that there's a pleural-based mass, or alternatively could also reflect the presence of like a loculated effusion, and those again are better assessed on CT. Then after that you want to make sure that there's no pneumothorax, so you're looking for any pleural separation, so you want to look around the entire lung. You can get lateral pneumothoraces as well, they're not always just at the top of the lungs. So looking for any pleural separation to look for a pneumothorax. If there is a pneumothorax, always remember, go straight to the midline and ensure that the trachea is still in the middle. The last thing you want to do is miss a tension pneumothorax, which would have a very bad outcome for your patient. So we're happy that that's fine, there's no pneumothorax, trachea is midline. And then what we do is move again, more peripheral, is to assess all the bones. Now, if you've got a clinical history that is trauma, then obviously the main thing you're going to be looking for is a fracture, so assessing all the various parts of the ribs, clavicles, partially image scapulae. And it's always important also just to have a look at the thoracic spine as well, because you can generally pick up like a subtle compression fracture or something like that, just by seeing either some wedging or some height loss. Again, predominantly in the context of trauma is when you'd be concerned for something like that. Alternatively, if you've got a patient history with cancer or something like that, then you'd always want to be looking for any destructive kind of bone lesions that could suggest, malignancy or metastatic disease. Now, sometimes you'll be lucky enough and you'll get a lateral image. Now, the main things in the lateral image that you want to be looking for is that it will confirm the presence of a pleural effusion. As you can see, these costophrenic angles are just these recesses at the back. So you'll be able to confirm if the presence of fluid, because the differential for blunting of those costophrenic angles is just pleural thickening. So if you don't see any fluid in the back here, then it's likely that it's probably just a small amount of pleural thickening. Assessing the thoracic spine, making sure normal alignment and no fracture. And if you do happen to have a mediastinal mass, which you see on the frontal projection, as we were discussing before, then this lateral image can help you localize to which part of the mediastinum it is, whether it's anterior, middle, or posterior. And that will help you target your differentials. So guys, that's my approach to a chest x-ray. So I hope that was useful, and there's some tips in there that you can put into practice. If you like this video, please give it a thumbs up. If there's any other kind of videos like this that you'd like to see, let me know in the comments below, and I'll catch you guys in the next one.